think we do have a veteran speaker. So Dr. Dobrowski did spend 8 years in the Army, being trained at
Walter Reed
Walter Reed Army Medical Center. That's where he did his internship and his surgery training in otolaryngology. He also went to his medical school was St. Louis School of Medicine. He right now is at Mass Eye and Ear Infirmary in the otolaryngology department. I would want to bring attention to the fact that our residents at the Mass General Hospital do rotate with him, where he teaches otolaryngology as well as sleep medicine to them, and they really enjoy working with him. He's been a great associate in training our residents. He's the director of adult sleep medicine and surgery at Mass Eye and Ear Infirmary. He's also associate director of sleep medicine and surgery. He's a member of the American Academy of Sleep Medicine, American Academy of Otolaryngology, American College of Surgeons. He's boarded in sleep medicine as well as otolaryngology. And he's going to talk to us today about a very important subject, which is polysomnogram, and it'll help us understand both the home sleep studies and the polysomnogram. So, John, I'll give you the lectern here.
Jeff, did you want to introduce anybody else and to say hello on the panel?
Well, we can. I should mention also that Dr. Gabby Caspo, our past president, is on the panel as well. And I know, Alan, do you want to say hello to everybody?
Yeah, no, thank you. And just a quick hello. And again, thank you for all the veterans that are out there, past and current. Appreciate your service to this country.
I'd like to echo that very much. In fact, as Jeff mentioned, I did my training at Walter Reed, both internship, residency, and then did my payback out in San Francisco. And so everybody says thank you for your service, but I should thank everybody because I got to live in Washington, D.C. and in San Francisco on the government dime and got wonderful training. And besides that, ran into people like Jeff along the way. But I now also help serve the veterans down in Providence, along with being full time at Mass Eye and Ear, which is now part of Partners program of Mass General, Brigham and Women's, Mass Eye and Ear, and a number of the other hospitals of Boston, all part of the Harvard Otolaryngology program. And as Jeff mentioned, I'm not only boarded in otolaryngology, but I also received boarding in sleep medicine, I was basically grandfathered in. That before they used to, before the fellowship programs were established, all of us that started in sleep medicine when Fujita was just doing the first UPPs, had to kind of learn a lot of this on our own. And so I had a lot of wonderful pulmonologists and other sleep specialists, neurologists that helped me along and guided me through the system, and a lot of self-learning. I eventually established my own independent private sleep center, and had it certified by the Academy so that I could receive reimbursements for all forms of sleep study. And that was done in Cleveland when I lived in Cleveland. Now I'm in Boston, and for the last 10 years, part of the Mass Eye and Ear and Mass General group. And so I come at the approach of sleep medicine from the ENT side of things and the airway side of things. And I will be talking a little bit about some of the differences between some of the studies that we're talking about in the evaluation of people for sleep medicine, for sleep apnea mostly, or snoring. So that's the beginning of our talk, the understanding of this, polysomnogram. And I have no commercial disclosures, and I'm having trouble advancing my slides. There we go. All right. So, part of our objectives here are to explain the differences between a home versus an in-lab study and the data that we obtained from both. I have to, excuse me, I'm having just a little technical issue. There we go. The data obtained and the benefits of each of these. We want to emphasize the validity of these home testing, which is become the gold standard. I'm sorry to say gold standard. Actually, the polysomnogram, an in-lab study, is a true gold standard, but everything is graded against that or judged against that. And but however, now the insurance carriers have certainly have a strong preference towards the home testing, mostly for financial reasons. And I want you to become familiar with some of the different terms and the criteria for the management for patients that have obstructive sleep apnea versus snoring, and in the management of the oral pain patient. Sorry, there we go. So back in the 1970s, and actually this is when I was finishing up med school, the Stanford group, Holland, Demet, and Renal. I've met Demet and out at Stanford a number of times when I was out in San Francisco, and they started to really put together a polysomnogram, that was a simultaneous multi-channel tracing of both respiratory, cardiac, EEG, the neurologic studies, the EMGs, which are musculoskeletal, and the eye movements. And they would grade it in 30-second sessions. And this was all done on paper with tracing. And you can imagine the old EKGs and how much of a nightmare that was to just get a good EKG tracing. We're talking about 6-7 hours of sleep time with multi-channels, ink, and paper tracings, and literally every patient would come out with literally a book of paperwork that would then be graded by a technician. So computers have made an absolute huge difference because they've been able to, digitize all of the information. We've also been able to pair video recordings with the in-lab studies, and now the home studies have also made huge inputs and advancements in sleep medicine and the ability to study patients effectively. So the parameters that were initially set up, and there are an entire rule book for grading the polysomnogram, and this is the full in-lab polysomnogram, and it's based on 30-second intervals and placements of electrodes in very standardized fashion. It grades the electroencephalogram, oculograms, chin movements, leg movements, cardiac ECG, nasal airflow, the respiratory efforts, oximetry. There'll be audio video of in the sleep lab of the patient to correlate with, and that is sequenced with the sleep study so that you can see both at the same time. There are snoring sensors. Not everybody will do esophageal pressure measurement. There's limb movement sensors. Again, esophageal pH is optional. Expired CO2 is also optional, but often used in the children's. And then there can be intercostal and diaphragmatic EMGs as well. So in putting this all together, you can imagine that there is a very standardized way that these electrodes are attached, and part of the problem and part of the training of the sleep technicians were how to put these on properly in the proper location based on these locations, and not only doing it for just one set, but you would do a backup set on the opposite side, so that if there was a failure of one of the electrodes, you could reference it against an opposite side. So it's in doing all of these placements and attachments, you end up with something like this. So you can imagine you're going to say, oh, we're going to send you to the in-lab sleep center and good luck in sleeping. And you can just imagine, I mean, you get all wired up and then people will look at you and say, and you expect me to actually sleep with all of this? Now, in the defense of the sleep centers, yes, people do sleep like this. And actually people that have severe sleep apnea have no problem falling asleep because they can fall asleep almost anywhere. But it's selling this as an in-lab study to maybe have them be evaluated and treated for sleep apnea or snoring is a huge undertaking. Besides the overall cost, you can imagine the manpower costs of first just the building cost of having beds and technicians overnight. With all this equipment and all this recording. So when home sleep testing came through, we are now looking at something as simple as this, and it's even been slimmed down even more now, with the watch pattern, which is testing the vascular tonometry of the fingertip and the information that is being gathered off of this. And through Apple, they have these downloads on your watch because it's picking up a lot of the vascular signals. They're doing there's snore detections on your phones, and so everybody is really picking up on a lot of your sleep cycles. And so I have to applaud the dentists because they were some of the first people to really jump on home sleep testing. There was a resistance by the academy initially to accept home testing as being a valid study. However, there's been, the insurance certainly jumped in on it and is now accepted as a wonderful way of gathering data at a fraction of the cost of an in-lab study. Looking at the montage of parameters that we are looking at in an epoch, which is a 30-second period of time. An epoch, EPOCH, is 30 seconds of a recording, and every 30 seconds is graded in a in-lab study as well as in a home study. On the left, you will see all the channels, beginning with the ocular channels at the top two. The next four are the neurologic channels, then chin mobility and muscular activity is in the red. The EKG, which most people recognize right away, the snoring channel, then our respiratory channels and movement channels of the thorax and abdomen, and then oximetry and heart rate. So that is a very, very detailed and is the gold standard of evaluation. And if there is a discrepancy or incongruity between what you believe is going on in a patient, or if the patient is having any of the movement disorders, then we have to use an in-lab study. However, most people will be evaluated for a home study by use of evaluated for sleep apnea by a home study, which you see on the right-hand side, which is almost a misnomer. It's really a respiratory study while you're asleep, and you'll see the oximetries, the flow channels, and then the some of the disruptions in the sleep. Now, initially, when the polysomnograms were created, they categorized different stages of sleep based on your EEG, and that has very specific characteristics that breaks people into wake cycles, sleep cycles that is non-REM and REM. So everybody might recognize REM as rapid eye movement, REM, and that is considered the dreaming stage, and it has a very specific characteristic. And if you look on the bottom right, you'll see that REM has a lower activity in terms of the EEG, but the EOG has these high sparked eye movements, and that's the REM activity of the stimulation of dreaming. But what also happens is that there is a paralysis of our body, so we don't act out our dreams, and so the EMG drops down to a bare minimum or hardly anything. Now, there are parasomnias that are REM movement disorders where people have disruption of that, and that can be a problem, where people act out their dreams and actually, can injure themselves. So sleep is broken into REM and non-REM. Non-REM can be divided in different categories, N1, N2, and N3. It used to be N3 and N4, but they've combined N3 and 4 into slow wave sleep, or N3. N2 is the majority of where most of our sleep is occurring, and N1 is the transition sleep from wake to sleepiness. On the left-hand side, you'll see some of the different encephalographic patterns, and so each of these stages have kind of a characteristic look to them. Stage, you'll see awake, then drowsy, where there is a little more regular pattern. Stage 1 then is the drowsy stage. Stage 2 is recognized by these spikes that are called K complexes. You'll see that on the left-hand side there, with that large spike, and also sleep spindles, which you'll see as a bulk of transmissions, and those are category of stage 2, and you know that you're fully asleep at that point. The deep sleep are these large encephalographic activity that is characterized by delta waves, and these are these broad waves. Then REM only accounts for about 20% of our sleep, but there's this very specific characteristic of a lower EEG activity, and a paresis of our extremities and body with rapid eye movement. Again, the sleep stages fall into stage 1, 2, 3, and 4, and REM. And again, just some of the physiologic factors that occur is that in stage 2, the heart will start to slow down, your body temperature starts to drop. In stage 3, there's muscle and tissue repair that occur, and neurologic cleansing that is essential for some of the rest and also memory consolidation, and then again REM with its paralysis and the dreaming. So again, just a reiteration of the different patterns of the different stages of sleep. And so these stages of sleep occur in cycles of about 90 to 120 minutes. And on the right-hand side, this shows the perfect, sleep with these beautiful 90 to 120 minute cycles where there's more of a predominance of the N3 sleep, the deep sleep in the first stages of the night. And so you will see some of the parasomnias of the deep sleep state, like night terrors, even some sleepwalking will occur in these situations. But earlier in the morning, REM will tend to accumulate. And so with REM or supine sleep, you might find a little more sleep disordered breathing, particularly snoring. And so I'm always curious as to what time of the day the partner may be waking up and starting to hear the snoring, and when some people are having more difficulty. When you look on some of the histograms of the sleep studies, you can see these groupings of sleep disturbances, and a lot of times they are following the REM patterns. You'll see these groupings together. The amount of N1 is due to, sleep fragmentation, and as you'll find out as you get a little bit older, there's more drowsiness and sleep fragmentation. And in fact, if you look through the cycles, the life cycle, you'll see that stage 2 stays very constant throughout most of our life. There's not much variability. REM also stays relatively stable with just a slight decline, but there's a real uptick in WASO. That's wake after sleep onset. So as you speak to some of your older patients, you'll find out more sleep disruption, more awakenings, and sometimes you also see that they have a little greater difficulty falling asleep. And there is a little bit more of the stage 1 and a real decline in that slow wave sleep, the restful sleep. So you have to look at how old somebody is and do they have, realistic expectations for slow wave sleep. You'll find on a lot of the apps that you can get with O-rings, these O-rings are the rings that people wear, and they give information about their oxygenation, and they give estimates based on algorithm and data interpretation of these different stages of sleep. The only way of knowing these true stages are with EEGs, but because of the heart rate and the blood oxygenation and actigraphy or activity during sleep, they're able to make these assessments with very, very surprisingly and very good analysis. And that's what brings us to our difference between a in-lab and the full polysomnogram, which have full montages of all of these characteristics that are being evaluated, and a home sleep test, which is dedicated, limited information. But we're making assessments and judgment based on this limited information with very, very good correlation. So some of the terms that are used, and you may get a report, and maybe your sleep specialist is talking to you about some different some of the different aspects of this sleep report, and so I want you to be familiar with some of them. These are the more common ones. First, the apnea-hypopnea index, or AHI. So that's the key number that everybody focuses in on, and is the addition of apneas and hypopnea. And apnea is 10 seconds, no airflow, and it can be either central or obstructive, or hypopnea, which is 10 seconds with a reduction of airflow and an oxygen desaturation. That's defined in two different areas. Medicare, or CMS, defines it with a 30% reduction of airflow and a 4% reduction of oxygenation, where the Academy of Sleep Medicine determines it by a 50% reduction of airflow and a 3% oxygen desaturation. So you can understand that some people are graded, and the commercial insurance carriers will accept a AHI of a 3%, whereas Medicare and therapy for patients is based on the 4. And we do have people that transition from commercial or and carriers to their Medicare, and they will lose coverage for the treatment of obstructive sleep apnea, even though they've had great success with it. Now, respiratory events-related arousals, or RERAs, you might hear about this. This is something that causes an arousal from sleep that doesn't meet those criteria of an apnea or a hypopnea, but it is the combination of these, the RERAs plus the AHI, that give you the respiratory disturbance index, which is a combination of the disturbances that are occurring or arousals based on either an apnea, a hypopnea, or a respiratory event that doesn't quite meet those criteria but still causes an arousal. The other thing that gives you a pretty good idea if people are non-smokers or are not COPD is your oxygen level. And we look at particularly your baseline, your maximum, and your minimum O2 level, giving an idea of the severity of the event, and the amount of time that is spent below 88, 89%, which we consider the floor of our acceptable oxygen levels through sleep. The total sleep time is important and can be very clearly calculated from a polysomnogram because we have the EEG levels, because there's a lot of time before sleep that you're still awake, but you may be getting drowsy and you're not quite in sleep. There are activities or arousals and wakefulness after sleep onset that are able to be identified. And when grading your apnea-hypopnea index, it's these events divided by the hours of sleep. Well, if you don't have a accurate total sleep time, then you don't have an accurate AHI. And that was the biggest concern of a home sleep test, because they couldn't determine exactly when somebody is asleep. Now, the WatchPat is able to, based on their calculations of an algorithm evaluation of the peripheral arterial tonometry. The home sleep tests estimate it based on some of the body positions, respiratory rates, and heart rate. But it's an estimate as opposed to a definitive number based on an in-lab sleep test. And so sometimes a home sleep test will be artificially reduced because you have a larger sleep time, and because the patient has turned on the machine, hasn't quite fallen asleep for maybe a half an hour or so, may even awaken at some point during the night. And it's hard, unless they inform the home sleep grading center of the amount of time that they were awake, it may create a larger denominator, reducing your events per hour. So I do a lot of coaching with my patients that are doing a traditional home sleep test, where I ask them to have everything set up, have them be a bit drowsy, maybe even go to bed slightly later than usual so that they fall asleep a little bit quicker. And I tell them we only need 6 hours of sleep. And that's something, for some people, that's hard to do. But so I tell them maybe go to sleep by 11:30. By 6 o'clock in the morning, we've gotten enough information. You happen to wake up, you turn off the machine at that point. We don't want you trying to capture that last hour or two, thinking that we're going to be getting a little bit more information about sleep. It actually is often diluting out the amount of sleep. And one of the things I look for is the amount of time that has been recorded and studied on patients. And if I'm getting a sleep study that has a recording time of 9 or 10 hours, I have to think about, has this caused an artificial reduction of my AHI when I'm talking about, do you qualify for sleep apnea, or, the severity of the sleep apnea. So sleep onset is exactly as it states. It's after lying down in bed and actually beginning into sleep and getting into an EEG pattern that brings on sleep and the electrophysiologic changes that occur. Sleep efficiency is the amount of in bed time, wakefulness, and sleep onset, and sleep and wake after sleep onset. So it's taking the amount of time that there's recording and actually taking your sleep time and dividing it by all of these other times to determine your efficiency or your percentage of amount of sleep. And then obviously sleep stages of non-REM and REM and wakefulness are the three big areas of sleep. And again, non-REM is broken down into stage 1, 2, and 3, 3 being the deep sleep, or some people call it the restful sleep, where a lot of restorative things occur. REM, again, the dreaming stage, rapid eye movement, REM, rapid eye movement with paralysis of the body and often if it's in a supine position, you'll find most of your events during those hours. All right. So again, the apnea-hypopnea index in an apnea is defined as full airway obstruction for 10 seconds. There's no airflow going in and out of the airway, and it can be described as essential or obstructive. Obstructive is the collapse of the airway, either in the oropharyngeal region or the hypopharyngeal region. I want you to be aware that nasal obstruction can make things worse or cause sleep disruption, but is rarely the cause of an apnea or a hypopnea. Some people's sleep is definitely improved by improvement of the nasal passageway, and it's one of the procedures that we do to enhance and improve patients' quality of sleep, particularly if they're using an oral appliance, but also when using CPAP, improving their airway. And so it will make some improvement of the apnea, hypopnea index, but is rarely curative for management of sleep apnea. So it's helpful, but the airway collapse occurs in the retroglossal region, the lateral wall collapse, or some of the soft palate elongation. Hypopnea, again, partial airway obstruction for 10 seconds with reduced airflow, and the Academy grades it at 3%. The Medicare or CMS is at a 4% oxygen desaturation. And this was in 2007 that, the Academy of Dental Sleep Medicine really helped push and received the verification by CMS and by the Academy of the validity of a home sleep test when comparing it to a standard in-lab polysomnogram. And this was the beginning of the explosion in the use of home sleep testing, and has actually become, particularly during COVID when we were not allowed to bring patients into the sleep center, home studies were then being utilized in order to minimize exposure to patients. And so the standard home sleep test using respiratory parameters was in 2008, and then by 2009, Medicare has accepted the WatchPat, which is the peripheral arterial tonometry testing. So the home sleep testing was initially designed for people that have as a confirmatory test for patients that have a high pre-test probability of moderate to severe sleep apnea. Unfortunately, that's been probably expanded and now used as the initial sleep evaluation and even screening for the difference between snoring and even mild sleep apnea. But it is not meant, and it is not valid for people that have complicated cardiopulmonary disease, patients that have respiratory muscle weakness or neuromuscular diseases. These things just do not lend themselves to using a limited study for true evaluation of their sleep. So patients that have these complicated issues often will need an in-lab sleep test. However, insurance often will say, you know what, we'd still like you to start off with an home study just to see if we can identify a problem with obstructive sleep apnea, treat the obstructive sleep apnea, and then if you're having difficulties with treatment, then we'll bring them in because of the cost of an in-lab study. Again, people that have non-obstructive sleep disorders such as central sleep apnea, hypoventilation, and sleep-related hypoxia, these are very complicated and not as common and require the full in-lab sleep study. Often patients that have stroke, they may have neurogenic impairment of some of the sleep centers and breathing centers. And anybody that's on chronic opiate medication, because they have a higher amount of central sleep apneas, are not particularly good for using a home sleep test. So what does the home sleep test give? Well, it gives, what we're looking for is, the assessment of the patient's airway. And there are two different types. One is, this is not supposed to have anything to, we try and not use trade names, but unfortunately, there are manufacturers that have their own algorithms and interpretations. And so ResMed makes Apnea Link and it'll come to me for a second, has the Night Owl apnea study devices that evaluate the airflow, whereas the final type of home testing uses peripheral tonometry. So this is a typical one from ResMed that looks at the apnea link information, and we're getting oxygenation levels. We're getting events that are either defined by apneas or hypopneas. The hypopneas can be scored at either 3% or 4%. And so that you're able to determine which, depending on the patient's insurance, which way you would like to interpret it. The oxygenation saturation gives us baseline, average, and the lowest, and then the number of events occurring below 88. And so in doing so, we also look at the patient's breaths, the number of snoring episodes per breath, and the patient's pulse. And so this is a study of every breath when the machine is turned on until the end of the night, and the correlation between their oxygen level and their airflow. And, this is what I have always felt most comfortable with because it correlated very, very well with a in-lab polysomnogram. This is the one study, and then this is the Respironics Night Owl sleep study report. So what you can see on this left-hand side, and I don't know if the pointer goes to this at all, but It does talk about the recording start, the lights out, and the sleep onset based on some of the parameters. But this sleep onset is I wouldn't say a guesstimate, but an understanding based on some of the parameters determining when it looks as though sleep onset has occurred. This is the greatest, if we're criticizing a home sleep testing, is the determination of the sleep onset and any type of wake after sleep onset. It is not very, very good at. Overall, it will give us our AHI, and it can be broken down into the number of central events, obstructive events, a mixed event. Then the hypopnea is either graded at a 3% or a 4% desaturation. And then the apnea hypopnea score. And then those scores divided by the number of minutes gives us the apnea hypopnea index. Again, you can see at a 3%, the apnea hypopnea index is a little bit higher at 8.9, whereas graded at a 4%, it's at 5.1. And you may understand that obstructive sleep apnea is defined by more than 5 events per hour. 5 to 15 events per hour is considered mild. 15 to 30 is moderate, and greater than 30 is severe. So in order to receive reimbursement for therapy, you have to achieve an apnea hypopnea index of 15 or above, or an apnea hypopnea index of 5 and above with comorbidity types of symptoms. That can be daytime sleepiness, cardiovascular issues. So we look for that cutoff of 5 events per hour. And if you cannot achieve that on one of these studies, then you will not receive reimbursement for the therapy that you're providing for the patient. Again, the number of minutes below 90, and then they also will give us the number of minutes that are in that range. It will also give you, and that's the number of oxygen desaturations per hour, to give you an idea of how many episodes they are having with oxygen desaturation, the lowest number or the lowest percentage that they're dropping to, and the number of minimum, how many minutes or seconds they're staying at that lower oxygen level, the highest level that they go to, and then the overall average here. We get heart rates so that if somebody may be in AFib, you may see heart rates as high as 120 or so events per hour, but so you're looking at a nice low regular heart rate in a normal sleep pattern. However, the mean sleep resting heart rate is very, very important, and the number of times that they are having increased amounts of irregular heart rates or the sympathetic release with an apneic event will cause an increased heart rate. So that gives you an idea of some of how much disruption they may be having in their sleep. What's nice is about most of the home sleep test is that you get a histogram, which is the overall evaluation and kind of a line item of number of events. And so you can see the grouping of a number of these events here, and then here, maybe in here. These probably are correlating with your REM state. You also want to see body position, because being on your back, that will promote, or supine, will promote more of the events per hour. Right and left is being recorded here, as well as prone. You are looking for any kind of unusual heart rate rhythms and oxygen desaturation that could just be related to a wakefulness episode, as opposed to a true cardiovascular event. So this is the standard home sleep testing. Now, the newest thing is the watch pat, and this is made by Itamar. And initially I didn't embrace this because it didn't give me a respiratory, basically a respiratory flow evaluation. This is all based on algorithmic evaluations of patients' peripheral arterial tonometry. It also has a actigraphy collection, which is detected on the chest, as well as so they do the oxygen levels, the vascular and microvascular activity of the sympathetic changes that occur at the tip of your finger, and the actigraphy and the snoring channels up under your chest. So there's 3 different sites of evaluation. It's a disposable type of home sleep test. It has a 98% success rate because it's very, very simple to put on. And you can certainly go to one of their websites and look at one of their videos of how simply it is used. They have certainly embraced it at MGH now, particularly for evaluation of some of the arrhythmias, and particularly in some special needs patients that may not even tolerate anything that is a nasal sensor around the nose. It's a wonderful way of also collecting data. And so I think that you have to understand that this provides a very low impact on the patient, a very good assessment of events per hour. But it is all based on algorithmic evaluation of the vascular flow rates. And it's kind of interesting, the vascular flow rate and activity is based on sympathetic alpha-adrenergic stimulation of the tip of the finger, and that's how they are able to pick this up. So their report is rather extensive because it's generated. It's a generated type of report in terms of algorithmic evaluation of the events. They do record the snoring and oxygen saturation along with the pulse rate, which are hard recordings, but everything else is calculated on a proprietary algorithmic evaluation of their of the data that is gained. From that, you get the PAHI, and they believe that they are able to also detect the central apneas as well as the obstructive apneas. But this has been acceptable by both Medicare and commercial insurance as a way of determining events per hour and for and achieving an apnea-hypopnea index that would be allowed to be reimbursed for treatment. And so I know that a lot of the treatment that is being proposed through the dental societies and through oral pain management is evaluation and management of the oral airway with oral appliances, with great care in terms of the management of the temporomandibular joint and the myofascial muscular stretching that occurs with advancement of the mandible. And so information gained from this can not only be used to justify and allow for reimbursement for these appliances, but also a way of checking on the therapy once it has been established. And a lot of times I'll have my patients that begin on an oral appliance wait until they have been using it or feel very comfortable with it after approximately 3 months to check to see the effectiveness. Now, I do have to say that oral appliances will sometimes leave people less. If you're just looking specifically at numbers, they may not achieve full therapy, but the patient's compliance and effectiveness of management and improvement of quality of sleep is much greater than the actual AHI number. And so our evaluation for effective therapy is somewhat based on this. It may not show us a complete resolution of events per hour, but most people feel that either a surgical or an oral appliance improvement of an AHI by 50% with a reduction of snoring is a huge success. You have to also understand that people that use CPAP, they define success for CPAP as 4 hours of night of use, 7 out of 10 nights. Well, what about all those other hours of sleep that they may not be getting, more than that? And so that we call that some of the untreated therapy. Whereas if you're using an oral appliance, you're probably using it far more than just the 4 hours per night. I want you to remember that sleep disorder breathing is part of a spectrum of our normal breathing, and that we're not always in an obstructive sleep apnea situation. There are periods of time during the sleep cycle that you have normal sleep. Also, people they just don't jump usually from normal into obstructive sleep apnea. They kind of pass through these different sleep disturbance categories through late adolescence or college into finally possibly having a more severe obstructive sleep apnea. Now, obviously, there are a number of children with obstructive sleep apnea, and I think as Dennis, you have certainly become very careful in the identification of upper airway obstruction with high arched palates, narrow palates, obstructing adenotonsillar tissue, narrow mandibles. And so these things, are being identified earlier on, and therapy is being initiated earlier with palatal expanders, tonsillectomy, adenoidectomies. Again, sleep disorder breathing is only one of a myriad of sleep disorders. Insomnia is probably the most common problem. It's only one portion of our whole sleep problem, but I do concentrate a lot on the sleep apnea patients. And incidentally, globally, there's an estimate of about 1 billion people between age 30 and 69 with obstructive sleep apnea. So there's a tremendous number of people that still need therapy. Home sleep testing brings in these people sooner, and we're happy about that. And obviously, the importance of the sleep is the risks of the heart and stroke, risk for stroke. Obviously, weight has huge impact. It improves adequate sleep, improves our immune function. Poor sleep is linked to increased inflammation, not only inflammatory markers in the gut, but other areas. Memory, concentration, productivity is definitely related to sleep, and as well as depression and athletic performance and mental fatigue, or overall function. So these are the importance of us continuing to manage sleep. Again, it's not all snoring that is a problem, and I would have you often think of snoring as just the tip of the iceberg of a much greater sleep disordered breathing, and not to ignore the symptoms of sleep, of snoring as only snoring, but to always dig a little bit deeper to look for other sleep difficulties. So I'm going to bring Jeff back, and any of the other panel members that may have some questions.
Hello, everybody. This is Maria Hernandez. Hi.
Hello.
This is Maria Hernandez.
Yes, Maria.
Co-chair of the Sleep Medicine Committee. Thank you very much, Dr. Dobrowski, for this fantastic presentation. So as you said, let's get started with the Q&A. So I have here one question for you. Do you think it is really worth it for us, for dentists, to use actigraphy to titrate the oral device, or should we just advance the patient's mandible based on clinical symptoms, since the patient will require a follow-up home sleep test or polysomnography anyway?
Right.
Thank you.
So actigraphy, honestly, is really meant for people evaluation of insomnia, not so much the respiratory. And it is not a reimbursable type of evaluation. What somebody can do is a overnight pulse oximetry, or they can use an O-ring to help assess how well they're doing on their device. I often rely mostly on patient symptoms after they have are using, and partners' observations.
Okay, thank you very much. I do have another question for you. Yeah.
Yeah, I'll go ahead and ask a question from Dr. Dobrowski. How does the lowest oxygen DSAT affect the determination of sleep severity?
So it's one of the parameters that I use in looking at the entire picture. So it's not the only definitive, because you could have a disruption of the the wiring, and so you could get a false reading for something that drops down to like a momentary drop down to 60, and you're like, wait a minute, is that a true reading or not? But if you're registering oxygenation of 20 to 40 or even an hour long periods of time that you are below 88, and you don't have a history of somebody that has significant, COPD or smoking or asthma, then you've got a very serious sleep problem that is impacting the person. I mean, seriously, if you were awake, you wouldn't want to be breathing or living at under 88. I mean, that you would be a candidate for oxygen therapy continuously. Now, after therapy, most people, once they are on therapy, their oxygenation doesn't drop down anymore. And in fact, in order to get additional O2 for patients with CPAP, it's like jumping through fire to try and get it approved, because they want to see not only, resting state O2, they want to see O2 on your CPAP. They want to see minutes of time under 88, and they even want to see exercise oxygen. It's very, very challenging. So most therapy will bring up that oxygen, and you can just do an overnight, if you want a recording that you can go back to. You can request one from one of the home sleep companies that supply CPAP. Home overnight pulse oximetry, they'll give you a great report, and that gives you an idea of how well you're doing. I'm very careful though with patients that have more than say 5-10 minutes below 88, then I think that increases the severity, and you have to start talking about, hey, we have to make sure and check to make sure that this has come up with any form of therapy that we're giving them.
Yeah, thank you.
Thank you. So we have another question here. So according to one of our attendees, so I've heard that home studies have reduced sensitivity for women. I would love to hear your thoughts on this. Thank you.
Well, I don't believe that is actually true. For women, after postmenopausal, they start to act, or there is a huge uptick of obstructive sleep apnea. So if you're premenopausal, you probably don't have obstructive sleep apnea unless you have very, very severe sleep apnea. It's snoring symptoms. So snoring is, as I showed on the diagram, it's the gateway to a greater problem. And so if you are having a lot of snoring problems, then you're probably having significant airway collapse, because it is the airway and the vibration of the airway that is causing the snoring. That, if you're having enough snoring and you're having daytime sleepiness, you absolutely need to have a home sleep test. And I have a lot of patients that are normal body weight, normal body habitus, that are female, that come but their snoring is the primary problem. And we find that they often will have at least mild sleep apnea, and then they may have some fatigue that then qualify them for therapy. Now, they may not choose to have CPAP, they may choose to go with an oral appliance, but that's their preference.
This is a very nice question, I think, about just doing a home sleep study one night. Is that sufficient to really be accurate in diagnosing?
Well, initially, when they first started to do even sleep studies, they weren't sure was one night enough, and they used to do them 2 or 3 days in a row, and it was just too onerous. So, by the numbers, if it doesn't seem right, if it's incongruous with what the patient's body habitus, their symptoms, and say you get one that comes back normal, you have to repeat it, and you can either repeat the same type of test, or you can bump it up. Now, sometimes the insurance companies will give you a little, resistance on asking for an in-lab test, but that's the final gold standard to go with it. You might have a really good night that night, and you might not get the data that you are looking for. And a lot depends on body position again. So if the patient sleeps totally on their side the entire time, they might not show the level of sleep apnea that they would if they were supine. A lot of people have learned to sleep on their sides and have gotten to that weight because they can't sleep on their back because they obstruct so much. So they've gotten in the habit of sleeping on their side. But what we usually like to see is in a sleep study is supine sleep in REM stage to see the severity of how bad things really are. The more time you can keep somebody on their back during a sleep study, that is going to give you the greatest chance for finding out the number of events or sleep disturbances. So one night is all they give us nowadays, and they feel that if it just doesn't correlate, do it again.
Good. What's the difference between home sleep test and smartwatch?
A smartwatch would just be limited parameters. The watch pat would be a bigger step up. So a smartwatch or an O-ring, these are single channel type of evaluations, whereas the multi-channel with a respiratory tract is a type 2, like polysomnogram is a type 1 sleep test. Type 2s are anything with a respiratory channel. So 2 and 3 are anything with respiratory. Level 4 is without respiratory, but multiple parameters. And then you have these other things that are the commercially available smartwatches and things like that, that are 1 or 2 parameters that may give you oxygen, some actigraphy, and your heart rate. So you get blood oxygen level, your levels and movements, as well as blood oxygen. So it's not a complete study. It gives you, people come in with all the data a lot of times, and I'm like, okay, that's nice. That does correlate, and over time, when you look at, how they're doing, it gives you some ideas. But unfortunately, we have certain studies that are acceptable by commercial and Medicare for allowing you to go ahead with therapy, and those smartwatches are not enough data. You can follow how well you're doing, but it's going to give you trends.
Good question about diagnosing bruxism, and what kind of sleep study do we need to be able to determine that? And I think that gets to the movement disorder question too. If the patient has a movement disorder, do we have to have a polysomnogram to help diagnose that?
Yeah, I'm afraid you do.
So for bruxism, you'd have to have a polysomnogram as well?
Yeah, I believe so, because I can't think of anything else that ties in the EMG aspect of the evaluation with the sleep study. I don't know of one. That
makes sense. And how about if a patient starts using a dental device and now they're dreaming where they weren't dreaming before?
That's a good sign. Very good sign. A lot of times we'll hear from our patients after treatment, either with CPAP or an oral appliance. Wow, besides I never used to dream before. Now I'm dreaming. They're quite vivid. I'm dreaming in color. It's pretty interesting. Some of it has to do when you wake up, because you tend to remember your dreams when you are coming right out of REM stage sleep. As the REM accumulates a little bit more in the morning, so you have a greater chance of waking up from REM or out of a REM state. And so you may remember it a little bit better.
Okay, I got another question for you. That has to do with when you're taking sleep medications. Say someone has insomnia, but they also have sleep apnea, and you give them sleep medications. What does that do to their sleep stages? And
so they that's a real problem. Okay, so most people, the Benadryl is the typical one. There's a little bit more relaxation, and it does affect you don't get in as much as N3 sleep as you do. It helps you get into fall asleep, but it's not as good a restorative sleep. Alcohol augments obstructive events because of the more of the relaxation that occurs. It helps you fall asleep, but then you have lousy sleep afterwards. So that disrupts some of the sleep. Some of the CBD oils and medications, there's the same thing is worrisome about it. It allows you to fall asleep, but then the quality of the sleep, it disturbs. The Zolpidem, the Ambien, some of the other sleep aids do affect some of the quality of sleep, as well as the antipsychotic things can also, Wellbutrin, some of these things, they all have some effect on the levels of sleep. And in fact, there's like when you're studying for your boards, you start to look at the parameters, and there's huge grids, and it's impossible to you have to go to the actual product and then look to see how is this affecting. And every product has a little different effect on sleep. It's really amazing. And different stages of sleep. There's very few that enhance N3 sleep, which would be the ideal type thing. And the use of melatonin is the one thing that does help with onset of sleep. It's a natural product, onset of sleep, and maintenance of sleep. So you're not going to do, a very good product to get people on to help them fall asleep is about 5 milligrams of melatonin, about a half an hour before sleep. The other thing is using a light box therapy that creates your own natural melatonin, and that will allow for onset about 12 hours later. So for people that have, particularly if they have affective, mood disorders and things like that, the light box therapy is very, very helpful. And during the winter months, it can be helpful in terms of improving quality of sleep as well as melatonin.
Well, that's great information. Thank you.
Thank you. What leads you to recommend a CPAP versus oral sleep device based on the sleep test results?
Okay, so it's been my opinion that, first of all, CPAP is still, I feel, the gold standard of therapy. However, it's not as well tolerated and people are not as compliant as an oral appliance. The oral appliance was initially designed for snoring as well as mild sleep apnea. It has less effectiveness with moderate to severe sleep apnea. It is really not indicated for severe sleep apnea. However, if you have a patient that can't tolerate CPAP, what else are you going to do? Because surgery is the least effective out of all of the events, out of all of the therapies, we may encourage an improvement of the nasal passageway so they may be more tolerant of CPAP or an oral appliance. But doing an expansion sphincterplasty is about 50 to 60% effective in terms of improving the airway. You would have to refer them for an oral, for the mandibular maxillary advancement in order to really enlarge the box for the airway. So I reserve often the oral appliance for snoring or for mild obstructive sleep apnea, maybe for mild, but definitely not for severe unless they are completely intolerant of CPAP. I usually offer CPAP first. It's a little bit quicker to get started people on. Generally speaking, they are paid for through insurance on a monthly basis. Within a month, within the year, you own the machine. So if you haven't had success with the CPAP, then you can certainly go to an oral appliance. Some people do that, and then they have both the oral appliance and the CPAP, and they can actually kind of go back and forth with those. They can use the oral appliance for travel. Clearly, they have shown that oral appliances patients are more compliant with oral appliances. The downside, as you know, with the oral appliances is how much stretch or strain it puts on the TMJ or anything in terms of the occlusion. But I think that is controlled, particularly with your understanding and particularly with the people that you're associated with that are very, very keyed into how much stretch you can put. And so everything is an acclimation as well. But and obviously patient personal preference will play into it. If I have somebody come in and say, there's no way I'm going to wear that, I'm not going to fight with them on them. I want them on therapy. So I will encourage them to use an oral appliance at that point.
A couple of questions about melatonin and when to take it. You mentioned 30 minutes, but I guess there's a couple of questions about the recommendations to take it 3 hours or 4 hours ahead of time.
Yeah, that if somebody is having great difficulties with sleep onset, taking it 3 hours before will help that. But if it's more the maintenance of sleep, half an hour before seems to work fine. Most people are fairly tired when they're ready to go to sleep, but they're having trouble staying asleep. So that's where the melatonin is particularly helpful. But taking it up to 3 hours beforehand. The problem is that there are some people that take it and then they get a little bit sleepy, then they get their 10 o'clock boost of activities, and then they've kind of lost their window to go to sleep.
Okay.
What brand of melatonin would you recommend?
I just have people use like go to CVS or Whole Foods or whatever and just get a national branded melatonin. I don't have a specific brand that I encourage, but I would encourage one that is a branded name. And you can find those at CVS or Walgreens or Whole Foods, any of those that seem to have some verification of the amount of melatonin in it.
So let's ask one last question, if that's okay with you, Maria. And unless you have a burning one that we haven't been able to ask, and this comes from Larry Lockham, and we'll give him the last question, Larry. And he asks about fibromyalgia patients that have very mild obstructive sleep apnea, but of course they're tired all the time. What do you think about management with those patients?
First of all, it's tremendously difficult patients, no doubt about it. And in any of those patients, any little bit helps as far as I'm concerned. And so I feel that if you can offer them a little bit of an improvement in their quality of sleep, that may offer them a little bit of improvement of their fatigue. And so I am all in favor of management and the use of, say, an oral appliance or CPAP to try and help them out.
Great. Well, hey, it's been, we've had about 15, 20 minutes of questions, and, the numbers of participants haven't dropped down. So everybody's staying on and really interested in what you have to say. But it was a really great presentation.
Jeff, I can't tell you how much I enjoy working with you. It's absolutely wonderful. You're just one of the nicest guys in the world. And,
well, thank you.
And
I would just say he's reading a script that I gave him.
And Maria, it's wonderful making your acquaintance.
Yeah, that's good. But thanks so much. And I think a good example of a vet, showing up on Veterans Day and really knocking the ball out of the park. Great job.
Thank you. I cannot salute all of our veterans more, and the people that are on active duty now. I'm very, very concerned around the world.
Yeah,
It's really becoming unstable. I'm very, very concerned.
Yeah, good. Well, thanks so much, John. And I should say that
being part of this group.
So if people getting CE, we're going to be sending you an email about how to get your CE, and you'll be able to go on the website and get your CE. So that'll be coming to you. All right. Thanks a lot, everybody.
Pleasure. So nice being here.
All right.
Thank you very much.
Bye-bye.